Welcome to another one of our series of Counsel to Prevent Opioid Dependence webinars, which focus usually on one of two topics: developments in research and on prevention and on opioid prescribing, and also information about non-opioid pain relief alternatives. Today, we're very pleased to have Lindsay Rosenthal, who is a fourth-year medical student and a skilled researcher in the areas of addiction medicine and opioid prescribing, to do an overview of what's going on, particularly around emergency surgeries and opioid prescribing, and to share some of the findings of some research she and her colleagues there at University of Michigan have conducted. So first we will do a PowerPoint that Lindsay will lead, then we will have a Q&A session. If you have a question for Lindsay, feel free to put it in the chat, but the first piece of business will be for Lindsay to give us an overview that we're all looking forward to. So let me turn this over to Lindsay now.
That sounds great. Thank you so much for the kind introduction. It's great to be here. I'm really excited to present to you all today a little bit about post-operative opioid prescribing, as well as some of the research that we're doing here at the University of Michigan. So let me share my screen and we can get going. All right, so yes, like as Rob said, I am a fourth-year medical student at the University of Michigan Medical School. And today I'll be discussing a topic that's very important to me from both an academic and a personal perspective. I'd be more than happy to chat about how I got here and what motivated me to pursue this sort of research in the Q&A session. But for the sake of time, I'll jump right into a discussion about prescribing and patient-reported experiences. So just a brief outline for the presentation today. I'll begin with a background about this topic in the context of the U.S. opioid epidemic, and then I'll segue into a discussion about my research and our early findings, and then we'll conclude with a Q&A session with Rob. So as many of you know, the opioid epidemic is a U.S. public health crisis. And although conservative distribution of opioids has grown in popularity amongst healthcare professionals, opioid prescribing has more than doubled over the last 2 decades. Leftover pills at patients' homes go unlocked, unused, and undisposed, which then increases the risk for diversion and non-medical use. Ultimately, this misuse can lead to injury and unfortunately death. Opioid prescribing patterns following elective procedures, meaning planned procedures like hernia repair or thyroid removal, have been well described in the scientific literature. These studies have shown that patients appear to be prescribed more pills than they report consuming on follow-up surveys. Interestingly, these studies have reported no association between the number of opioid pills prescribed and increased patient satisfaction or improved pain, which are outcomes that we refer to as patient-reported outcomes, or PROs. We often use these in the healthcare outcomes and quality improvement research sphere. Simply put, this suggests that more opioid pills prescribed to patients do not necessarily correlate with happier patients or patients who are more pain-free. When reviewing the literature in preparation for the project I'll discuss shortly, I noticed that there were few studies examining prescribing after emergent procedures. In surgery, we define emergent as a procedure that needs to be initiated within 24 hours of a patient's presentation to the emergency department or to another acute healthcare facility, and this is generally judged by the acuity and the severity of the patient's condition. An example of this sort of procedure would be an emergent gallbladder removal, or what we call a cholecystectomy, if the gallbladder is a source of infection or causing any other organ systems to dysfunction or shut down. Here's an example of adult prescribing recommendations for elective or planned procedures for patients that undergo surgery at Michigan Medicine and the University of Michigan Hospital. These guidelines were developed from research similar to mine, investigating relationships between post-operative opioid prescribing and patient-reported consumption. In brief, the studies that led to these guidelines found a discrepancy between how many pills patients were prescribed after their surgery and how many pills they reported consuming. And therefore, these guidelines were established to narrow this gap and mitigate misuse of opioid prescriptions via leftover pills at patients' homes. Given that there are few studies examining opioid prescribing patterns following emergency surgery, it is unsurprising that there are no official clinical guidelines, similar to the ones in the slide prior, to standardize prescribing in the acute care setting, like the emergency department or urgent care. There are a number of factors that make studying prescribing patterns after emergency surgery more difficult than studying prescribing patterns following elective surgeries. First, there is more variation in surgical procedures and indications. Emergency surgery is a large umbrella term with many procedures falling under it, which leaves room for a lot more interpretation and prescribing preferences amongst different surgeons and emergency providers. Second, patients have inconsistent follow-up after an emergency encounter. In theory, patients should have follow-up with a primary care or specialty provider after a visit to the emergency department or other acute care facility, especially if they're prescribed opioids. But many don't follow up, and therefore it's challenging to track opioid consumption following an emergency procedure. Finally, emergency surgeries vary greatly in severity, acuity of pain, and recovery time, all of which contribute to difficulty standardizing opioid prescribing guidelines after these surgeries. Instead of just working with one type of surgery in one part of the body, we are working with many types of surgeries spanning the human body, from the gallbladder to the appendix to penetrating abdominal trauma and lots of organ systems in between. Understanding opioid prescribing following these emergency procedures is important for a few reasons. First, the burden of disease is significant, with over 3 million patients admitted to the hospital following these surgeries, which occur at a rate of about 6 million procedures per year, and this rate is going up. Second, the emergency department is the first setting in which many patients encounter prescription opioids. If patients' initial encounter with opioids is in excess, it makes sense that this increases the risk of misuse and diversion, especially if they are not allowed especially if they're not educated on proper disposal of extra pills following a procedure. Finally, there's increasing number of emergency department patients getting discharged with opioid prescriptions, regardless of whether they have undergone a procedure or not. For that reason, it's critical to understand opioid prescribing patterns in this setting to mitigate this population's contribution to the ongoing opioid epidemic in the United States. Given this gap in the literature that I've described previously, the objective of my team's study was to investigate the relationship between opioid prescribing, consumption, and patient-reported outcomes in emergency surgery patients in the state of Michigan. In order to do this, we used the Michigan Surgical Quality Collaborative, or MSQC, for our database. The MSQC collects clinical and patient-reported outcomes from patients presenting to 69 different hospitals in Michigan. The outcomes we looked at were prescription size, consumption, quality of life, regret, and pain score, which are the patient-reported outcomes I described prior. In our cohort, or the patients whose results we analyzed, we had about 3,700 patients that met our study criteria. The most common procedures these patients underwent were laparoscopic appendectomy, laparoscopic cholecystectomy, and minor hernia repair. The mean number of pills prescribed to these patients was 9.6 5 milligram oxycodone tablets, and the mean number of pills consumed was 4.6. After doing a logistic regression, which I'm happy to explain in the Q&A as needed, we found no association between pills prescribed to patients and their reported satisfaction, regret, or quality of life, but we did find an association between the pills prescribed to patients and the pills that they reported consuming, such that for every one additional pill prescribed to patients, they reported consuming just over half a pill, and this is demonstrated in the graph here on the right. And so what does this mean, aside from all of the research jargon? In sum, the study demonstrates that the patients only consumed about half the opioids that they were prescribed after their emergency surgeries. Furthermore, patients who were given larger prescriptions consumed more opioids, but did not experience higher satisfaction, better quality of life, or less regret to undergo surgery. This suggests that opioids may be excessively prescribed to patients undergoing emergency surgical procedures, and that larger prescriptions do not improve the patient experience after surgery. Therefore, an important aspect of combating the opioid epidemic in the setting of emergency surgery will be responsibly prescribing opioids postoperatively to limit patient consumption for non-surgical pain and possible adverse events following discharge. These are my references for my presentation. I'd be happy to share any of these papers with anyone who might be interested. And now I'd be happy to transition to a Q&A with Rob.
Great. Probably want to take the, there we go. Lindsay, as usual, is a step ahead of me. Just wanted the slide to, the very nice slides to disappear, and they did. So let's back up a second, Lindsay, because I know you've also done other research in this area, general area, not just this specific study. What got you interested in the area of addiction and prescribing?
Yeah. So a story that some folks might be familiar with from my father, Josh Rosenthal. So my family experienced a pretty significant loss when I was a senior in college in 2016 from when my elder brother, Nathan, died from a fentanyl overdose, which he had been struggling with addiction to opioids for a number of years, and unfortunately lost that battle in 2016. And I think after kind of the initial shock from that wore off, it became really clear to me that doing something, whether it was in the field of research or healthcare or both, sort of to help patients and individuals like my brother, was going to be something that was really important to me. So when I first started looking for jobs after graduating college, both of my first jobs actually were in clinical research in addiction medicine. One was at Mass General in Boston. The other one was at NYU in Manhattan, and doing different studies, but both really, it was more in sort of the realm of psychiatry, looking at different treatment modalities and ways of helping folks who had opioid use and other substance use disorders, sometimes with additional sort of mood disorders, but primarily just substance use disorders. And then when it kind of became clear to me that patient care was really important in addition to clinical research, by the time I got to medical school, and I started getting excited about surgery and a career in surgery, sort of the logical next step to me was figuring out how to sort of marry the two, an interest in a career in surgery and an interest in addiction medicine. And that's kind of what brought me to doing this type of research.
Thank you, Lindsay, for sharing that story, which unfortunately, if we look at and as you alluded to, if you look at statistics and you look at, I know I work with a number of people around the country. Last year we lost 85,000 people in the United States to an opioid overdose, with fentanyl now being the prime driver of that, and it's the leading cause of accidental death in the United States. And there's a lot of people a lot of impacted families, and a lot of people have joined you in different ways in attempting to, do something so that other families don't have to go through what your family's gone through. So now to turn to your presentation, did you, one sort of other impact of opioid prescribing is, for some people, not everybody, but this research shows, is not only the one thing you mentioned, which is the potential for misuse, and because people don't clean out the family medicine chest. That's how teenagers start often, but it's also the risk of dependence for people that get started, and for some people it takes as little as 5 days to become dependent. You looked at that issue
in terms of sort of long-term use after
Yes,
initial.
after I know that wasn't within the scope of this study, but
Yeah.
what's your general impression of that?
Yeah, no, that's a great question. I think, although, like you said, not in the scope of this study, but this stays similar, but members of my research team have started looking at long-term effects of postoperative opioid prescribing. And sort of their early work has demonstrated, and again, this is in Michigan, but their early work has demonstrated that postoperative prescribing can lead to long-term and chronic use. And they've even suggested sort of correlation with substance use disorder down the line. And there are particular risk factors that can predispose patients to developing chronic use after sort of their initial prescription. One of those risk factors being opioid use prior to surgery. And so it being their first encounter, but them having used, whether it's in a prescription setting or not, prior to the surgery. And then also the amount that they're prescribed after. So sort of they've showed a trend that the more opioids you're prescribed after your surgery, the higher the risk that sort of you might develop chronic use, which makes sense, whether it's leftover pills or just more days of use from sort of the pills that you have.
Yeah, very interesting. And there was a study done in Stanford that makes a similar point of people of wisdom teeth extraction and the difference between people who were prescribed opioid painkillers for pain relief for wisdom teeth and people that were given non-opioid alternatives. And it was 3 or 4%, which doesn't sound like a big number, but if you think about just like with emergency rooms, you're talking about 3 million surgeries or whatever it is, 4 million surgeries. With wisdom teeth, so many teenagers getting their wisdom teeth out, for about 3 or 4%, a year later had some kind of opioid. We're still using opioids in some fashion. That's a big number. While the folks that weren't prescribed opioids, not surprisingly, that a very, very, very low infinitesimal percentage were using opioids after. So it's also I hate to use the word gateway because it's been used in ways that I think are inaccurate about certain substances, but it can be for some people who are more predisposed to become dependent fairly quickly, either for what you suggested, they have past opioid use, or for other reasons, and some reasons we don't even understand, we'll never quite understand because of their brain chemistry. The one thing your study obviously showed is the less prescribing, the better. Wonder if you've also looked at, there's a couple programs, I don't know if it would work in an emergency room context, but there's a program at Maimonides Hospital in Brooklyn where they're doing breast cancer surgery. I can obviously plan a little bit more. With non-opioid pain relief methods afterwards. There's a program in Paterson, New Jersey called the ALTO program, Alternatives to Opioids, where now this isn't for surgery, this is just general emergency room, but 3 out of the 4 people who come to the emergency room with pain leave without an opioid prescription. They try other things. What do you think of approaching, and by the way, at the Maimonides Hospital, my understanding, I'm not the skilled researcher you are, but my understanding is that the pain relief studies show not, that their pain, the pain relief regimen, non-opioid that they've come up with in pain studies does as well for pain relief, generally speaking, as pain relievers. What do you think some of that would be realistic in an emergency room setting for emergency surgery?
Yeah, so I think that the research demonstrating, and this is, again, like you said, not much has been done sort of in the emergency surgery sphere, but increasingly, and again, sort of I can more or less from a research perspective and more from just a experiential perspective here at Michigan, at Michigan Medicine, there has definitely been a sort of a shift in trying to use, whether it's multimodal analgesia, so opioids plus something else, so you're still using opioids, but you're using fewer of them, or something else using, yes, other modalities entirely. One thing that I think has become pretty popular is IV Tylenol, or in like different types of strong NSAIDs that can help patients relieve their pain without sort of the risk of addiction. I think in the emergent setting, it's a little bit more challenging just because of the severity of injury. But I definitely think that there could be improvement, especially following discharge. Even if patients are given opioids in the acute setting, once they leave the hospital, what they're given to manage their pain could be a little bit different in terms of whether at least sort of like less focused on opioids. I also think another important thing that we talk a lot about in surgery and in like sort of the patient education sphere is really sort of setting patient expectations about how much pain they can expect to feel after surgery. So if patients are expecting to be completely pain-free after they get their surgery or after they're discharged from the hospital, the likelihood that they use too many opioids or request refills is much higher than if we tell them, hey, you're going to be in a lot of pain after the surgery and it should get better. And this is sort of the timeline that you should expect. But if there's less of an expectation of being completely pain-free and more of an expectation of it being a process, then I think patients are more likely, like I said, to request refills and ultimately use fewer strong pain medications, whether it's opioids or other medications that can still have an effect on sort of your body's chemistry.
I think it's so important because as you know, Lindsay, some of the genesis of the opioid epidemic, which was the prime driver of which was the overprescribing of opioid painkillers, still overprescribe them generally speaking. We're still north of 100 million a year, about 140 million a year around the country. So one for every 2 Americans, essentially, prescription every year. It used to be, 250, 260 million, but part of that was well-intended. Part of it was the sort of pain scale that got such emphasis because
Yeah.
and the emphasis on pain, which is obviously when they want to be in pain, but the 1 to 10, 1 to 5 scale, something you know much more about than me, and the notion that there should be, I shouldn't say no pain, but that should be prioritized over everything else, and there were obviously unintended consequences.
Mm-hmm.
So I think that's the point you raised there about for everybody, whether you're in an emergency surgery setting or any kind of setting where you're going to experience some pain for also for patients to have a real set of expectations that after some kind of surgical procedure that you're going to be pain free on day one is just not realistic.
Mm-hmm. Exactly.
It's good to know that is not getting built into medical education. So in your medical education there at University of Michigan, are you do they deal with safe prescribing as a piece of the curriculum, or is that something you sort of pick up in your research?
Yeah, that's a really great question. I think there's been a push recently to integrate it into our education. I think as a medical student, it's a little bit challenging because we can learn, in textbooks or on, online modules about safe prescribing and sort of learning different morphine equivalents and how to do those calculations and all of these things in theory. But because we don't have sort of, for lack of a better word, prescribing power as medical students, like we can't send patients home with prescriptions. We don't really have practice doing it. So I think there's been an effort to integrate it into our didactics or our lecture-based learning, but because we can't really send those prescriptions, we don't really get that hands-on experience. But I do think sort of the next sort of level up in medical education is then becoming a resident after you graduate from medical D and then go on to your training in the hospital. I think at least here at the University of Michigan, I think residents are educated reasonably well, at least again, most of my experiences in surgery, about how to prescribe responsibly. I'm not sure that's necessarily how it is across the country, but certainly here.
What we found is when you're in sort of a well-regarded academic medical institution like the one at the University of Michigan, that is more the practice. As you move away from those, and this is generally speaking, there's probably great hospitals everywhere, not trying to throw
Yeah.
it, but as you move away from there, those practices are less generalized. The good news is now that anyone who prescribes opiates, once you know become a doctor, does have to take continuing medical education on safe prescribing. That's now required by federal law, at least a certain number of hours.
Yeah,
Many
absolutely.
states also have ongoing continuing medical education requirements in the area of safe prescribing. So there have been, you know, improvements in that over the years. You mentioned you're going to go into orthopedic surgery, or that's one of your goals. Um, Another interesting area, because there's, and I can see how you want to combine that with sort of addiction medicine in a sense, because we found is sports injuries, understandably, are one of the sort of sources of initial opioid prescriptions, and unfortunately for some people, advancing into an opioid dependence problem and graduating to heroin or fentanyl or something. And that's not for everybody. And so we do a lot of work with coaches and with high school athletes, because that's one of the entry points. So why don't you talk a little bit about how you think you might combine those two things? I know you're sort of at the beginning of your although you've already had even though a short so far, a very distinguished career in all these areas, but as you enter and become a full-fledged MD, how do you envision that?
Yeah, that's an excellent question. Something I've definitely been thinking a lot about as I'm gearing up to start residency in the next year or so. I think, I mean, it's quite aligned with some of the work you guys are doing. At the moment anyway, a patient population that I'm really interested is young adults and adolescents, athletes, but also kids who are born with congenital orthopedic issues. And that can result in, for example, scoliosis and the procedures that follow to sort of straighten out kids' spines who are born with curvy spines, and then sort of how to manage their pain after that. And one of my mentors here at Michigan, she's a pediatric orthopedic surgeon. She has done significant work looking at sort of like what we were talking about before, multimodal analgesia following scoliosis procedures and spinal fusions that's sort of pediatric appropriate, and also allows kids to get out of the hospital sooner, because it's also been shown the longer kids stay in the hospital, often the more sort of psychological suffering they have, in additional to physiological troubles. So I think, sort of following in her footsteps, I'm really interested in sort of figuring out pain management strategies that still help kids and young adults experience pain relief from whether it's their traumatic injury or congenital issues, but also prevent and mitigate sort of chronic opioid use or dependency down the line.
Very interesting. And as you know, because I think you mentioned you looked at some treatment options as well earlier on in some of the research you've done, and just watching a lot of families go through this with one of their family members, and watching people in recovery, and also just looking at the numbers. Treatment's so essential, so critical, but it is hit or miss. Even the best evidence-based treatment, which is why our focus, even though we support more treatment, we support more Suboxone, we support all the things and all the research to make treatment more effective, it sounds really obvious and trite, but as if you can prevent people from starting in the first place, that we think that's one of the bigger keys to stopping the opioid epidemic. What did you find in looking at the different treatment modalities?
So there's been a ton of work, I would say, in the field since when I was doing the work as a clinical research coordinator a number of years ago. But I think, again, some of that work was preventative. So, for example, early screening in the primary care setting. So if you come to your primary care provider and you're given sort of a screening tool to sort of see if you are at risk or maybe already have either an alcohol use disorder or substance use disorder, and picking that up quickly, sort of like we were discussing before, so that you can either get early treatment or early prevention, kind of looking to see whether or not that was helpful in early diagnosis. And then one of the clinical trials we were working on was in young adults with comorbid substance use disorder and bipolar disorder, and looking at whether or not a mood stabilizer, Seroquel, was beneficial to these kids. And it was challenging because Seroquel, as folks may or may not be familiar with, is a drug that has a ton of side effects. So it's really figuring out, okay, if this is helping either a young adult substance use disorder and or mood disorder, is it worth all the risks from the side effects? And that study was in its early days. And I think I followed up with my PI like a number of years ago at this point, but it looked like it was helpful, but that especially for, kids in their late teens, early 20s, those side effects were no joke. And it was really a matter of whether or not they were willing to tolerate it. But I think for adults with opioid use disorder, as you've mentioned, I think Suboxone is a really important drug. I also think that having strong social support and group therapy can be really helpful. But ultimately, I really think that it's important for sort of providers to take an individualized approach, because some people respond really well to pharmaceutical therapy, some people don't. Some people respond really well to group therapy, some people don't. So I think really taking, a really patient-centered approach and not kind of like a one-size-fits-all is super important.
Thank you, Lindsay. That was a very helpful answer, I think, for the people who are watching, some of which are also either in recovery or family members or close friends of people in recovery. And it's as you know, it's a hit or miss, touch and go odyssey. But there are people who come out on the other side too. So I want to minimize that. That's critical and essential. This has been a terrific conversation. Is there anything we missed that you wanted to add before we close?
I don't think so. I think we covered quite a few bases. I'd be happy to discuss, anything more, answer any other questions that viewers might have. I can share my contact information, and anyone can feel free to reach out because it's something I care a lot about and would love to engage in conversation about down the line.
That's great. We'll send around, and with your permission, we'll send around to all the participants or the viewers of this a way to get in touch with you if they want to know more specifically about your research. We actually had a couple inquiries already from people in the medical research field, which we will forward to you if we haven't yet. So I want to thank you very much. I think this is very informative, very helpful. This webinar will also be available for if you want to share it with your friends or any viewers on our website, as are all our past webinars at ctpod.org. And we will, and this series will continue periodically, so we can bring people information about how to prevent opioid dependence, about developments in the field, and about non-opioid pain relief alternatives. Thank you very much, Lindsay Rosenthal. Really appreciate it, and I appreciate everybody. Thank you. Thanks very much.
Thanks for listening.